Hi, everyone. Welcome to the Animal Heartbeat, your vet cardiology podcast. I'm Jose, and I'm here with Kieran, and we are professional veterinary cardiologists and amateur podcasters.
Amateur, even on season 2.
We'll always be amateurs. We have another great episode for you today. Professor Adrian Boswood. Adrian is a professor of veterinary cardiology and the vice principal for learning, teaching, and assessment at the Royal Veterinary College. I'm sure anyone that has read a paper in veterinary cardiology has come across with Adrian's work. I wanted to say that more important, or as important as achievements in cardiology, Adrian cycles like 25 miles per day. And 10,000 miles per year, which is that right? Or those figures right?
But probably more 7,000 or 8,000 miles a year.
Okay.
Yeah, but yeah.
Yeah.
You're the most cardio
impressive
of cardiologists, I think. Well, impressive.
Sadly, it may be getting to the point where it's not so good for me, but there we are.
Welcome, Adrian, and thanks very much for joining us today. Tell us a bit about your own career path on clinical research and especially why are you interested in clinical research?
Yeah, it's very interesting to kind of reflect on my career path, because there was a period in my early career where I thought that the last thing that I ever wanted to do was research.
Right.
I was kind of thoroughly into growing up to be a big clinician one day. And I really wasn't particularly interested in research. And a number of my contemporaries did residencies and then went on to do PhDs. And I didn't. I did a residency and then went straight into a clinical position. But after a while, it basically got to the point where I kept coming up against questions for which there weren't answers. And it suddenly dawned on me that the way I was going to get answers to those questions was actually to carry out some research. And looking back on that sequence, I think some of the people who were my contemporaries who went into PhDs answering someone else's research questions ended up not really enjoying it. And over time, I just kind of became more fascinated in trying to answer questions that I was interested in. And it turns out that when you try to answer questions you're interested in, that's research. The other thing, and sometimes I ponder, is having not had such a conventional research training may actually end up making me approach questions slightly differently. Consequently, sometimes now I'm no longer referring to myself. This is the generic thing, but sometimes the interesting questions come from outside the mainstream. And some research trainings basically train people to operate within the mainstream and not see things in an alternative way.
Right. This is a nightmare of a question, potentially. How would you define good clinical research?
It's a very interesting question about where the boundary between what some people call basic research, some people talk about applied research, some people talk about clinical research, and I think if you're going along that spectrum from basic to applied to clinical, clinical research is closer to the patient and more likely to enable you to draw a conclusion that can be applied back to patients fairly soon.
Right.
So the basic research is often about answering some quite fundamental questions, which seem to be quite a long way away from being able to do anything that will be of benefit to patients. But
that's where the journey begins, isn't it?
To some extent, yes. Although there are some fascinating examples of where the clinical research may have been done before the basic research has answered some of the questions.
Right. Okay.
I mean, I could expand on that briefly, but
Sure.
if you look at, for instance, the current example in human heart failure of SGLT2 inhibitors,
It's fascinating. Yeah.
and it seems to be that all of the evidence to support the administration of SGLT2 inhibitors has come from clinical research done in trials on patients. But if you ask the basic scientists how it's working, they don't know. They all disagree with each other.
And in fact, in some parts of that discussion, they think it should do the opposite of what it's doing. And I guess that they're reverse engineering now to understand it. But that's fascinating stuff, isn't it?
Yeah, exactly. And so you don't necessarily, I mean, it's a bit of more of a gamble, but in that situation, you can see the benefit without the basic research necessarily telling you why it's happening.
For the people listening to us that are planning a clinical research project or are aiming to write a good paper or a good study, can you give us like 2-3 tips of what people should aim for to find the right research question, how to start the right project?
I think that the right question is definitely where you should start. If you look at the mistakes that people tend to make, veterinary studies always have that sort of classical problem of being underpowered. So there are too few observations from which to really be able to draw good conclusions. The other thing that I think clinical researchers tend to do is to answer too many questions with a single study. And consequently, what they do is they say, oh, yeah, well, while we're doing this study, we'll just do this and we'll do this and we'll do this. And you make the study incredibly complicated, often quite costly. And then at the end of it, you have a whole lot of data that you don't really know what to do with. Whereas if you keep your eyes focused on your single research question and address that simply in a large-ish population, it will probably be more effective. So I'd say don't be distracted by secondary hypotheses, follow a single question, design a study taking into account power, and make it as simple as you possibly can.
Regarding numbers, as you said, most of our studies are underpowered because it's challenging to recruit cases. It's difficult in longitudinal studies to not lose patients to follow up and so on. Is a challenge. So how can we overcome that challenge? Should we all aim to have multi-center studies? Should we all aim more to collaborate with other centers in order to have bigger numbers?
Often the reason that you need big studies is because of what's called the effect size that you're expecting. And so if whatever it is you're investigating has a profound effect, then you don't need to subject many patients to that in order to see a clear outcome. And you could take examples of things where if you don't treat the patient, they die or deteriorate very quickly. If you do treat the patient, they respond amazingly, and you don't need very many patients to show that conclusively. So when you need to have a lot of patients is where your effect size is smaller, is where it's going to be less obvious that a patient has benefited from the treatment that is being administered, for instance. And that's why the power of a study really depends on two things. It's the number of individuals in the study and the effect size of the treatment that you anticipate. Big effect size, small numbers will still show it. When you're getting into the stage of looking at sort of, say, if we focus initially on treatments, where you're looking at an incremental benefit of a treatment on top of other treatments, that's likely to be a fairly small effect. And therefore, you're likely to need quite a lot of animals in order to show it. When you need a lot of animals, you probably need a lot of investigators, and so you need to do multi-center studies. But the other big benefit that people tend not to think about quite so much with multi-center studies is that having a study addressed at multiple sites actually reduces the effect of potential biases at single sites. You always have to be a little bit distrustful of a study where everything was done in a single site. So was there something intrinsic to that site that only they can do, which would mean that the study then wasn't very generalizable? There's a benefit beyond just multiple numbers. There's actually tends to be a benefit associated with generalizability. And then the other benefit of multi-center studies is you have to get a group of people to agree on how to do things.
Not always so easy, right?
Exactly. And so what you've got to do is you've got to get people doing, let's say, measuring the left atrium in the same way, measuring the left ventricle in the same way, because you've all of the animals going into the study have got to meet the inclusion criteria in the same way. And actually what that tends to make you do is step back a little bit from the protocol and say, okay, well, is this really something everyone can do? Which also then makes the study easier to subsequently apply in a population. So if you take a single center, and if a new cardiologist has come up with this fantastic measurement that only they can do, and they use it as an inclusion criterion for a study that shows a profound effect of a drug, that's absolutely no use to anyone because no one can do that measurement.
Yeah.
And so what a multi-center study makes you do is come up with a protocol that numerous people can run rather than just one person, which automatically makes it a study that's more likely to be generalizable.
Yeah. How do you factor on that operator variability? Because as you were saying, of course, that is more a real life situation. Many different cardiologists, clinicians measuring the case, different geographic, genetic pools, environmental factors, and so on. So would make certainly the cohort, the population more robust. But then we have, of course, operator variability. Is operator variability then diluted when we have big enough numbers? Is operator variability diluted, or is it still important but less important than having numbers in real life scenarios?
Operator variability is inevitable, and there's intra-operator. So if I do the same thing to the same dog on different days, I'll get different measurements. And then there's inter, where if two different people were to do it, they'd probably get even more different measurements. You can look at it one way and say, well, that introduces a weakness or a variability within the data. For sure, it does. But the thing is, if what you're then doing is you're publishing something and it's going out into the public domain, and thousands of people suddenly are going to be applying your method of identification of patients or something else. In some ways, your study's got to be able to withstand some degree of variability in order for you to be able to draw conclusions, and you'd say, that's okay, that's life. You're never going to get everyone to be absolutely precise. The other thing is that it might be kind of a curious way of looking at it, but if your measurements were so variable actually as to be just kind of producing gibberish, then you shouldn't see a treatment effect. Because your measurements that you measure at the outset are just so rubbish that there shouldn't then be any association between those measurements and any outcome in the study. So it almost you kind of almost reverse validate your measurements by showing that they are associated with the outcome that you're interested in, even with the variability of having multiple operators. There will be measurement variability. One of the reasons I've speculated about this quite a bit is that if you look at, for instance, the two main measurements that were inclusion criteria in the EPIC trial on echo, left ventricular measurement and the left atrial measurement. And we did a longitudinal paper where we looked at the change in those values over, I think it was something like the first, I should know this, about first month, I think. And
we can edit that in. It's all right.
That's fine. It's fine. Yeah, Adrian's forgotten. No, I think it was about a month. When you looked at change over the first month, and there was a difference between groups, but the change from the first measurement to the second measurement in left atrial size was much greater across a much greater range than the change in measurement between left ventricle from the first measurement to the second measurement. And actually, I think that's just because left atrial measurements are much more variable. So you get the same person to measure it in the same dog a month later, you get a much wider variation in measurement from left atrium than you do from left ventricle. So yeah, there is measurement variation there. You just have to accept it.
So you mentioned the EPIC study. I'd love to come back and talk about that a little bit more. Just focusing on what you said about applicability, or rather generalizability of data. Yeah. Most of the work we read is performed in referral practice.
Yeah.
And obviously referral practice is a tiny, tiny stratum of the animals that are looked after by vets across the world. So how can we overcome that? What must be a huge bias there? Partly in what you're saying about measurement and sort of inclusion and identifying which animals will benefit from treatment, say, but also how a vet performs something. If a procedure is highly specialist, then it's not something that can be generalized to primary care practice. What can we do to overcome that? Is that something that's within our control?
There's a way that I have thought about research, and I've said this to various people before, so some people may have heard this, but that there's kind of two types of research. It's a massive oversimplification, of course, but there's what I call top-up research and there's top-down research.
Right.
And the likelihood is, just because of the type of people who want to undertake clinical research are likely to be fairly specialized, that they are operating somewhere near the top of their particular field, be that cardiology or internal medicine or surgery or whatever it is. And you can choose to do research that makes that small number of specialists better, and so that's top up. And what that does, though, unfortunately, is it takes those people even further away from the average level of care that can be provided in practice.
Sure.
The other thing that someone can do, but I think there's a risk here of being slightly patronizing, is to do what I would call top-down research, which is research that is intended to be applied in general practice, bearing in mind the limitations that there are to the sorts of things that people can do. And just by the very nature of specialists, I think there's a tendency for specialists to want to get better and better and better. And so a lot of what's done by specialists in specialty practice is what I would call top-up research.
Right.
It's like, how can we be even better at diagnosing dilated cardiomyopathy? Or how can we come up with this really funky new intervention for this extremely rare form of pulmonic stenosis, or those sorts of things?
I feel very seen.
This one was for you, Kieran.
That's fine. We're all friends here.
Adrian didn't mention HCM, so it's fine with what I do.
Exactly. But there's nothing wrong with that. But as soon as you take that choice, you're moving into an area where it's not going to be applicable to people working in general practice, other than you telling them, "Hey, I've got this really funky new treatment for a really rare disease."
Sure.
But what's much more difficult is to take a finding that you've got and then simplify it without oversimplifying it to the extent that it can be readily applied in practice. Now, one example that I would use of that at the moment is, and you said we'd come back to EPIC, and I'm sure we always will. One of the things that we recognized pretty much immediately after publishing EPIC was the inclusion criteria required, at the very least, echo, and they required accurate measurements of left atrium and left ventricle, which took it out of the range of the ability to be applied across all general practices. There are some general practices where left ventricular and left atrial measurements can be taken perfectly well, but there are some practices where there isn't access to that machinery, there isn't access to that expertise, and basically the choice is the patient goes for an echo, or we just guess. You working in cardiology practice no doubt will have seen quite a lot of patients where in the end the vet guessed. Sometimes they guess right, sometimes they guess wrong, and often it's just on the basis of how audible the murmur is as to whether or not the dog goes on to Pimobendan.
Yeah, absolutely right.
Yeah, and so one of the questions that we wanted to address, and this is in Jenny Wilshaw's Hamlet study, was with what level of accuracy can we identify dogs that would fulfill the EPIC inclusion criteria with much more widely accessible tests. Now, cardiologists might look at that and go, "Oh my God, you're going to be wrong 10% of the time," what a complete disaster. But if what it ends up is that if you average across a whole population, that the level of accuracy of intervention has increased at a population level, then actually what you've done is improve the standard of care.
Yeah.
And it's about letting go of that obsession with referral level accuracy for something that can be implemented in a practice setting, with busy people push the time without the expertise, so that the general level of administration of care to patients is improved. But it's about designing interventions that allow you to do that, rather than somehow expecting that things that specialists do can be applied in primary care practice.
It's fundamental, isn't it, I think, to focus on that population level of care.
Yeah.
And an interesting thing that I've found is, speaking in different places across the world, and I know you're both well identified with this, practice looks different in different places. And what people do is very different. And I remember years ago, I gave a lecture. I emphasized the years ago because it was in Russia. The landscape was quite different then. But I was speaking at the Moscow Vet Congress, and I've been asked to give a whole lecture on cardiac biomarkers. So I gave a lecture on cardiac biomarkers. Obviously, it was super entertaining, brilliantly put together, nicely paced, everything, And at the end, someone put their hand up and they said, "Well, why wouldn't we just do an echo?"
Yeah,
and I said, "Oh, well, you see, not many people are doing echo. Obviously, you and I are doing echo, but not many people. Who in this room has access to echo and echoes more than one case a week?" All of the hands went up in a lecture hall of 350, 400. And then I said, "Oh, well, maybe it's cost. Echo's expensive. How much is NT-proBNP?" And they said, "Oh, it's like $300. Okay. Echo's cheaper and more accessible in some places. But obviously it still comes down to measurement accuracy, experience. It's not as simple as having an ultrasound machine, is it? It's really interesting that obviously the applicability of the research to practice looks different in different areas.
I'm going to say something sort of intentionally a bit mischievous. Okay.
How unlike you.
I think there's this really curious thing that, and you may have heard me say this before, that there's this curious thing in veterinary cardiology, I think actually much more than human cardiology, that we identify ourselves with the tests that we do. Huh. In human cardiology, you go and see a cardiologist, then they send you off to a technician to do the echo, and then you come back with your echo results, and the human cardiologist looks at the numbers. In veterinary cardiology, all the cardiologists do their own echoes because that's what defines them. And I once came up with the word the echocracy, in that we rule because we echo. There's a frightening prospect on the horizon, and that is AI. And imagine if AI could do fantastically accurate volume measurements just on all you had to do was stick the ultrasound transducer on the side of the dog, vaguely near its heart, and it would come up with all of the measurements that you ever wanted, probably more accurately than an individual cardiologist could do it.
A nice 3D transducer gets a full volume,
Exactly. A few cardiac cycles. And then the question that I throw out to the veterinary cardiology community is, what are you going to do then?
Pulmonic stenting.
There you go. You'll be the stentocracy.
Yeah.
It's
a growing number of us.
Yeah. You have to be that we have to be defined, I think, and this is what we find frightening in terms of how we think and how we approach things,
Right.
rather than actually the things that we do.
Yeah.
And that will still distinguish specialists, but it won't be on the basis of our capacity to echo.
And it's perhaps something that the internal medics are more comfortable with, because actually I always think of the medics as being the brains. You have the imagers will do the ultrasonography, the clinical pathologists will look at the cytology. Yeah, all right, the medics will drive a scope, but I mean, it's just video games, isn't it? But they're comfortable with being the brain and integrating all that information to make decisions and make a plan, and it's admirable. But I think the AI thing's really interesting. And in humans, some of the guidelines now are saying to use the automated measurements wherever possible.
Right. Really?
So, if you've got your ECG, it'll automatically pick up your aortic outflow and give you a VTI. No actual measurement needed, just acquisition to get the pictures.
Adrian, regarding the point before about doing research that is useful and that we can generalize or translate into primary care and so on, because of course that's such a hot topic and an interesting topic. I always kind of struggle and think where randomized clinical trials fit on that, because I see the danger of doing a prevalence study or to use a referral population that is high. There's lots of referral biases. We see a very high prevalence of disease X or Y. And of course, that doesn't mimic what the general practitioner sees and so on. But if you are thinking about a randomized clinical trial, as the natural history of the disease and how the disease responds to a drug is hopefully similar in a referral center, tertiary center, and primary care, is it okay then to do a randomized clinical trial as the ones you led, EPIC, PROTECT, and so on referral centers? Or should we ideally also run randomized clinical trials already on a primary care setting?
The difficulty becomes, and I sort of referred to this a bit already, that if the tests that you use to either include animals in the study, and so to differentiate those that require treatment from those that don't, for instance, so often that will be your inclusion criteria. If you use tests in your inclusion criteria to which general practitioners don't routinely have access, then what you've automatically done is excluded them from the ability to truly apply the results of the study. And so if you look at what the sorts of things that they talk about with some human trials, is doing what they call pragmatic trials, which are very simple inclusion criteria, and it only works for certain things, but do very simple inclusion criteria in an effort to make the findings of your study very easy to apply into a primary care setting. And that one of the things that I have learned is definitely think very carefully about what it is that would get an animal into a study. This next bit is again pure speculation. If you ask why did we choose the inclusion criteria that we did for EPIC, the aim of EPIC was to demonstrate whether or not pimobendan would delay the onset of clinical signs associated with valvular heart disease. And so really the purpose of inclusion criteria was to identify a population of dogs that you thought were at risk of progression. And because of the way that we understood the natural history and the progression of the disease, that actually illustrating the importance of prevalent studies, for instance, we knew how the disease behaved. So we knew that an at-risk population were dogs with big hearts. So we looked for dogs with big hearts, and that's what we recruited to the study. Is that the only way that we could have identified a high-risk population? I would say the answer is probably no. It was a way. Now, if you look at other independent indicators of risk in dogs with mitral valve disease, and you look back at some stuff that we published years ago, a risk of progression to the point of death in mitral valve disease is predicted independently by heart size and biomarkers. And so biomarkers are an indication of risk for reasons that we don't entirely understand, that may be independent of heart size. We could have gone back and done that study all over again and recruited animals on the basis, for instance, of an elevated N-terminal pro-BNP concentration. And we don't know that the results would have been very different. So this is now when I'm getting into pure speculation. So please don't think I'm saying treat them if they have a high NT-proBNP, but just imagine how different the world would be if we hadn't relied on echo, but we'd showed the same outcome.
So what would you, if you would go back, would you try that now? Would that be a more
epic too?
Yeah.
If my career was long enough, the next two steps would be validate the algorithm that Jenny Wilshaw came up with for identification of stage B2 dogs in a primary care setting. Funnily enough, that might be a study that we're planning. And then if you show that with reasonable accuracy you identify P2 dogs in a primary care setting with that algorithm, then rerun something like the EPIC trial, but using that as your inclusion criterion. And then all of a sudden what you've done is you've missed out the need for an echo because you've demonstrated benefit in dogs that meet those inclusion criteria.
But it's not at the right path, because to me, you first showed that using the gold standard, if you want, clinical gold standard, that screening, enrolling dogs with these features, then they will profit from that drug. Not, and then you try to break it down and find different ways to bring that drug to the general public. You were already very careful with which echo variables you choose, because you could very easily gone very fancy, and not even crazy fancy, but just Doppler inflows and systolic function, blah, blah, blah. And some people may criticize, oh, you didn't include more advanced ways to assess mitral regurgitation, whatever. So I think you were already very careful using two simple ways to assess echo changes.
And that comes back to that earlier point that I made. In a multi-center study, one of the things you need to be reasonably confident is that every investigator will measure it in the same way.
I can't even estimate mitral regurgitant fraction the same way twice on the same day. I mean,
exactly. And so when you look at measurements that have such incredibly wide variability, even in expert hands, if you give that to 20 people to do, it will be not very helpful, I think would be the polite phrase.
It sounds like a very reasonable, sensible path. The way you did it, and now you step back and see how can you help general practitioners if you want. But if you would go back 15 years back, would you say stop there? Let's try not to use echo. Would you attempt that? Or
no, I think it would have, because you have to bear in mind two audiences with a study like that. There's the audience of the practitioners who will apply your results, but there's also the audience of your peers and the people who'll peer review the paper before it gets published, and the people who you have to convince that your study findings are valid. And I think if we'd done a study like that without echo, we would have been sort of pilloried for wasting time.
People would have said, well, how do you know?
Exactly.
How do you know they had bad mitral valves?
Yeah. Well, that's a philosophical question, but then that has an impact on how we design studies and how we come up with research ideas, because we want them to be publishable. We want the reviewers and the editors to accept the data.
But theoretically, you could do a bulletproof study. Because what you need is inclusion criteria, you need a measurable outcome that people care about, and so that your endpoint, and you need to show that something that you're doing is altering the likelihood of that outcome occurring, and so if you get that sequence right, it should be that study is defensible and coherent and everything else. People are always going to say, why didn't you do X? Why didn't you measure this really fancy thing that I've published? And because that would have made your study so much better. And you have to keep coming back to the point. It's like, we did what we did. Is that a coherent study design that demonstrated that animals like this benefit from treatment? And then the animals like this are the ones that you then apply the findings to afterwards. So everyone will want to redesign your study for you.
A couple of quick points to talk about with the EPIC study. I know let's not talk in massive detail about methods, because I know people can read the study out there, and a lot of people who are listening will be already very familiar with it. There's a couple of things that I love about the EPIC study. So number one, I think it's great that, as you said earlier on, we have a very simple question that's meaningful, to a disease which is super common and everybody sees it. That's great. From that data set, it was so massive and so well characterized. There are 3 papers there which are from the same cohort of dogs. And I think that's great. To be able to look at different aspects of it is fantastic. And for me, that, EPIC 2 and 3, if you like, sort of snuck up on me. And they're things that I think I'd seen you and Sonia and other authors talk about at meetings. But it was very interesting, actually, to read that paper with nicely polished statistics and figures and things. And the second thing that I think is super cool is the demonstration of a placebo effect.
Yeah, that's fascinating.
And that's
isn't
just
it?
wonderful to see that. What are your thoughts on that? Expand a little bit for the listeners on that.
One of the things that the study actually illustrates is the importance of a placebo group, because what we showed was there were some basically client associated outcomes that we measured, which were things like exercise tolerance, cough frequency, some general quality of life measurements. And we measured them at the outset, and then we measured them a fixed period of time afterwards. And if we had only looked at the effect in the treatment group, we would have shown a significant difference, and we would have gone, wow, hey, look at this is really significant. But actually what we showed was that for some of those quality of life parameters, there was a significant improvement in the placebo group. Now, of course, this isn't self-reporting on the part of the dogs. So this is an indirect placebo effect. It's the placebo effect on the owner reporting their perception of what the animal has done after going on to a treatment. And yeah, that was kind of a fascinating finding, because I've occasionally presented results to audiences of I would say human cardiologists, but all cardiologists are human. These are cardiologists who treat human patients. And one cardiologist put sort of I think just partly jokingly said, "Why do you need a placebo in a veterinary study? Because the dog doesn't know whether it's on treatment or not," which then makes you unpick it. And it's like the whole point of the placebo is to blind the vet, so that's us, and is to blind the owner. And it's nothing to do with actually what you do to the dog, but what that's shown is that the placebo effect is real through owner perception, which is fascinating.
And I think, looking back at the historic literature, from the 90s, in veterinary cardiology, there's some interesting studies there with some which report results which just haven't been repeatable. And if you look at them, there's no placebo group, and you think, well, okay, actually, maybe that was some bias in the reporting rather than the genuine effect.
There's also the possibility, of course, that it's the other thing you have to separate out. Is it a placebo effect or is it a temporal effect? In that for every dog, it was remeasured a month or so afterwards. And the reason I talk about temporal effect is there's another study, I think Jonathan Elliott was involved in it. It was one of the amlodipine in cats licensing studies, where they showed at the second visit a drop in blood pressure in the placebo group. And that was probably, and if one is an effect of time, and the second thing is it was probably an effect of acclimatization. So the cats were getting used to the fact that their blood pressure was being measured, which also illustrates the importance. While we're talking about kind of statistical quirks, one of the other things that I think is a statistical quirk that we showed in the EPIC second paper was what I would call regression to the mean.
Oh, that's interesting stuff. Yeah,
because if you look, and I think it's particularly for the left atrial measurement, that there is a significantly lower left atrial measurement in the placebo group at the second visit. And you kind of think to yourself, well, why on earth is that? And the reason, and this is where you get to regression to the mean, if an animal had to exceed a value to get into the clinical trial, if you're measuring animals and you one day you tend to slightly overestimate, the next day you underestimate, if there was a dog whose measurement was bang on 1.6, say, if you echoed that dog and you underestimated it, it didn't get into the study. If you echoed that dog and you overestimated it, it got into the study. But the next time you echo it, the value's closer to the true value for that dog. So it looks like it's come down. So as soon as you select for something high on inclusion to a study, the likelihood is if you measure it again, it will just come down through regression to the mean. So that's another little statistical quirk, which I quite liked.
Yeah, it's neat.
Yeah, it's very interesting. And then there's a really also nice study, neurology study, where they try different anti-epileptic drugs and a placebo. And the placebo group also decreased the amount of seizures, or there was a decrease in the amount of seizures the dogs had. And I guess also relates walks and wane of the disease and then regression to the mean, because certainly clients will seek veterinary attention when the dogs are having more seizures. And then over time, those seizures will just improve naturally.
You have to be skeptical about stuff, even if it's published and it's out there in the literature and people think that it's real. Read it for yourself. One of the things, kind of flying off at tangents, but one of the things that I like to encourage people to do when they're reading a paper is they read the paper through materials and methods, which of course most people choose to not to read. I always feel sorry for materials and methods because it's the most underread bit of any manuscript. But
there's a number of human journals where you have to find that online. You've got to go looking for material.
It's just bonkers.
Not even there.
But that's actually where all of the sins of the investigators are hidden in the materials and methods. But anyway,
the devil's in the detail, isn't it?
Read the materials and methods, read the results, and then what if you have the luxury to do so, don't read the discussion for at least 24 hours, and ask yourself what you think the results mean, and try and draw your own conclusions from the results. Because if you go straight from results into discussion, what every author does in their discussion is they use the discussion to convince the reader of their interpretation of the results. And as soon as you've read someone else's interpretation of the results, you're much more likely to agree with it. And so if you can get to the end of results, be brave enough to draw your own conclusions and then read the discussion and see if you agree with the authors. An awful lot of the time, maybe just because of my nature, I choose to disagree with the author's interpretation of their findings, even if they're perfectly valid findings. But yeah,
those are really great tips, and thanks for that. I just wanted to go back to what I was previously saying, because what I meant with that is I like beta blockers in general. I don't know why. Okay. I think they are an interesting drug and with a lot of potential. And when it's
about to get controversial.
Exactly. Yeah. It will be quick. When I see that, or people saying that there is no evidence supporting the use of atenolol on cats with HCM, for example.
Yeah.
It's just that I don't think there's evidence at all, because the studies were very carefully designed, very, very carefully designed. I think there are very, very good studies there they try to do their very best, but it's such a difficult disease to define, such a difficult disease to follow over time. So I don't think the data out there shows that atenolol is not useful or is useful in cats with HCM. And so that was my point. Is just that if we are lucky enough to have a study that was well designed and then was able to follow the patients until they had the outcome of interest, because that's of course the other big thing. We cannot really say if the drug is useful or no.
I think the difference between the findings in humans and the findings in veterinary patients with beta blockers is absolutely fascinating and completely unexplained, as far as from my opinion, because the evidence is so strong for a benefit of beta blockers in human patients with heart disease. Depending on how we classify heart failure, there's that transition between the two, and the evidence is so absent in veterinary patients, or the bits of evidence that there are, actually tend to suggest a potentially detrimental effect at some stages. Often in small studies, I think you'd have to accept, often in relatively underpowered studies because they were small, but because people got their fingers burned with those studies, then they didn't take them further. The other thing that again, I'm kind of skipping about, but there was a point I wanted to make earlier that I don't want to lose. Having been involved in the Quest study and the Protect study prior to the EPIC study, the wonderful luxury of the EPIC study was that there wasn't an effective known therapy for that stage of mitral valve disease. So it was a truly placebo-controlled study. And there were no ethical questions about withholding treatment from the placebo arm. So what you ended up seeing is genuinely the effect of the drug, because it was being compared to nothing. And the difficulty in any other trial, particularly with stage C disease and later, is there's always going to be discussion and argument about how do you standardize the background therapy that patients must be on from an ethical perspective. How do you account for the fact that cardiologists are going to adjust that therapy, even if they can't adjust the therapy of interest or the placebo if an animal's on placebo? So there was something really nice about a truly placebo-controlled study, where there was no need for any other treatment, and it really genuinely was the treatment effect that was coming through rather than the confounding effect of other therapies.
I think with heart failure, that there's all the cardiorenal aspects, which just complicate things. Obviously, preclinical, I mean, obviously it's not just that the kidneys get sick on the day they develop pulmonary edema. Obviously, it's not a hard cutoff like that. I appreciate that. But it must be less of an issue for dogs with earlier disease than it is for later disease, and therefore it simplifies things. I think one of the interesting things that's come out of some of the sort of disease registries that are out there, and it must be something that you see in your mitral clinic as well, is this balance between the mitral valve disease and comorbidities that we're seeing. This is a geriatric population of dogs. Is that something we can standardize for if we're looking at patients with heart disease, or is it something we should standardize for because it's the real world and animals have more than one condition when they get older?
One of the benefits of having animals with comorbidities in clinical trials, if you've got a big enough population, is it makes them representative of the general population. And again, exclusions mean that you genuinely don't know whether or not the treatment would work in a patient with that comorbidity. What you have to hope, and this is really one of the purposes of randomization, is that in a big enough population, if you randomize them, you'll end up with equal numbers of comorbidities in the two groups. That's just what usually happens. So you've got a choice with comorbidities. Do you allow them into the study and just hope randomization will sort them out? Or do you exclude them from the study? Or if they were really, really important comorbidities, you might somehow try to stratify your randomization so you end up with equal numbers in each group. So that's another way you can deal with it. But I think what's more important is to include them if you can. What we did with EPIC, and I think we've used the same wording in other studies too, is to exclude animals with diseases that we thought would be life-limiting within a year, something like that.
That makes sense, doesn't it?
So if they've got effectively the equivalent of terminal cancer or severe renal disease or something, then they don't get into the study. But we want animals in there with some comorbidities because that's real. You mentioned the mitral valve clinic and you mentioned disease registries. The really interesting thing looking at the mitral valve clinic population that I follow is the majority of those dogs don't die of their heart disease. The majority of those dogs do die of some sort of comorbidity, and the comorbidity that it doesn't appear in any disease registry anywhere is kind of the sort of thing where old age just caught up with that animal. It went blind, it went incontinent, it had osteoarthritis, it started peeing in the house and falling over, didn't eat its food anymore, and all of its teeth were rotten. So the owner chose to put it to sleep. It's like, how do we classify that as an outcome in a patient? And it may be that the dog having relatively mild heart disease contributed to that decision.
I was going to say that's definitely that's really hard to assess, isn't it? Is that philosophical sort of decision making of it's just too much, and of course the heart's part of that. If somebody knows
exactly,
oh, he needs medicine for his heart because his heart's bigger than it should be, that will impact on their decision making.
Yeah, but you haven't got like a sliding scale from cardiac to non-cardiac where say this one was 37% cardiac.
How cardiac is it? About 7.
Yeah. Yeah, exactly. And that's one of the things that's very real, but very difficult to deal with in just kind of a progressively aging population. That the other when you look at what you can get out of big data populations, or relatively big data for veterinary populations, at least like the look mitral population, which is lovely.
Right.
3,000, 5,000 dogs, I forget the absolute number, but the sort of the descriptive information you can get from populations like that is fantastic. I mean, just even looking at prevalence data, when you're looking at actually when you've got a population that big, even all being seen by specialists, because the look mitral dogs are all seen by cardiology specialists in the US, it shows you how prevalent stage B1 is, how relatively uncommon stage B2 is by comparison. I think it's about 75-25. Right. And then how then on top of that, how relatively uncommon it is for them to progress to stage C. And so when I see now, just on the basis of information like that, and talking to owners of dogs with valvular heart disease, kind of 15, 20 years ago, with the perspective of referral bias, where what I tended to see was dogs with more advanced disease.
Right.
You'd see a dog with valvular heart disease and say to the owners that, oh, well, it's got valvular heart disease, and quite a lot of dogs it progresses and they'll die of their heart disease. Now, truthfully, I could say if I see a dog with stage B1 disease, I can say to that owner, more dogs die with this disease than die of it. And it's a relatively benign disease that typically takes years to progress. And to be able to confidently say something like that on the basis of knowledge of true prevalence shows that prevalence studies have a real value.
And I think this brings us right back to something we discussed at the very beginning of this conversation, which is that B1, B2 thing.
Yeah.
Do we just treat because it's got a murmur? Well, when we know that only 25% of them would benefit from that, the answer should be obvious. But I think partly getting that information out there, because most people in practice, and certainly this is the case from my experience when I was in primary care practice, where do you get your research data from? Well, if you attend conferences, you might get it from there. So I started attending the Veterinary Cardiovascular Society as a practitioner, and that was invaluable for getting some perspective. Otherwise, it's drug reps, and drug reps don't want to tell you, not many dogs will need this. And that poses challenges in itself.
But there's also there is a difficulty in terms of how you can interpret the data that is available, because I could tell you that there's a question that I've asked in some kind of interactive CPD to see how people respond. And it's based actually on prevalence data, some of it from the Look Mitral study, and also some of it from the Hamlet study. So Hamlet study had about 1,800 dogs. Look Mitral's got about 4,000, 5,000. And the question I ask is, at what grade of murmur does it become more likely that a dog is a stage B2? And you have to listen carefully to how that question's worded. So at what grade of murmur is it more likely that it's a B2? I could tell you a number, which is that most B2 dogs have got a grade 4 or louder murmur, and the median murmur for a B2 dog is a grade 4. And a lot of people would take that and say, oh, grade 4, B2. But because B1 is so prevalent, there are actually more B1 dogs with a grade 4 murmur than there are B2 dogs. And so actually, if you look just at grade 4 murmur, you're still more likely to be a B1. The only murmur grade at which there are actually more B2 dogs is a grade 5 murmur.
Wow.
So if it's got a thrill on the basis of probabilities, you could say, well, there's a reasonable chance that it's a B2. But even with a grade 4 murmur, it's still more likely to be a B1 just on the basis of prevalence.
That's really food for thought, isn't it? That's great.
Yeah. Yeah. So but there's a level of sophistication of understanding of prevalence there, that I think you have to get that message across about what's the actual question that you're asking. Because what you know as a clinician is the grade of the murmur. You don't know the stage of the dog. If you tell someone lots of B2 dogs have got a grade 4, to interpret that statement, you already need to know it's a B2. But as a clinician, you only know its murmur intensity.
Yeah. The two things that I think facilitate meaningful research, aside from a great question, is money and time.
Yeah.
So, Adrian, research is expensive, and we need funds to run research, and there's a limited amount of funders available. And of course, pharmaceutical companies are a big source of study money and funders. And so it makes sense that they are sponsoring the biggest randomized clinical trials. So is this an issue? Is this a problem? Does pharmaceutical sponsor studies bias the results? And how can the reader read the article and be confident that this is true, and the investigators have not been biased by the pharmaceutical company?
No, I think that's a very good point. I mean, first thing about time is make it simple. If you come up with an echo protocol in your study that requires 50 measurements to be taken, then busy people aren't going to do it.
Yeah. You're going to forget. You're going to miss one. Yeah.
Exactly. And then the other thing, kind of money relates to time. If you're being paid, just a reasonable fee for the research that you're doing, then you can probably convince your practice that you should participate in it. But then that comes down to the question of who's going to pay for the research. And in human medicine, there are big national funding organizations who can decide priorities, and everyone agrees that human health is an important thing. So there is a benefit to studies being conducted, and there are big funders out there who will fund them. I think in veterinary studies, what we have to recognize is that the people who have the greatest interest in the outcome of pharmaceutical studies are going to be pharmaceutical companies. And what we need to be able to do, I think, is to step away from the perception that all pharmaceutical funded research is somehow poor or biased. That there is undoubtedly poor research that is sometimes done, but I think the important thing of a clinical researcher who can be independent of the sponsor of a study is to sort of mediate that relationship, where what you can end up with is questions being answered that are important to both parties by a sufficiently unbiased study that everyone can believe the results. But it's almost as though that as a trial investigator in that situation, part of your role is to add independent credibility to a study by making sure that it's done well, and then going out there and to propagate the results afterwards.
What I think is also remarkable to me is that certain drugs will never be studied because they are cheap and they are not of interest. That digoxin, no one will pay a study to study digoxin. Well, furosemide will never be studied, but my concern more with bias.
But 20 years ago, someone might have said that about spironolactone. Because 20 years ago, spironolactone was a very cheap generic drug that didn't have an awful lot of interest. And so I think there are some molecules that have been sort of brought back from and studied very carefully by pharmaceutical companies with an interest in demonstrating that those drugs are effective. And actually, you'd have to say it's a very brave step, given that the only way that they can recoup the costs of doing a study like that is by selling enough of the drug afterwards. It's a bold step.
Watch this space for rapamycin, I think. I have a follow-on question, which relates to the pharmaceutical funding, actually. How important is the concept of a publication guarantee?
I would be uncomfortable going into a large study without the guarantee of full access to the data and effectively a guarantee of publication afterwards. The individual investigators can ask themselves their own sort of moral and ethical question from the point of view of how comfortable they are with that. One of the ways that I would think about it is these studies take a lot of time and a lot of effort. And if you're not going to get something out of it at the end that is of value to both the investigators, the authors, and the bigger sort of readership, why do the study? The only reason might be, and this you have a choice. This is probably something I wouldn't choose to do if you were being exceptionally well remunerated for it. That you might do a study with a clause in it where you weren't necessarily automatically going to be given the right to publish if you got paid more for it per patient than you would do in another study. But that's the studies that I've done. We got at the outset written into the contract that there was a right to publish, and I don't think I would have done them otherwise. And I think even publishing negative studies says something good about the authors and the sponsors.
Agreed. And the journal. There are some journals who just won't publish negative studies.
Yeah. I mean, if it's a sufficiently well-powered study, and negative, then I think it's a really valuable addition to the literature.
Yeah.
I would love us to have enough time to discuss it. I think negative trials, as you were saying, are incredibly important to publish and so on. If we have time, if you can give us your opinion in 45 seconds. So we have a trial that was designed for a certain primary outcome, and that was negative. Right. How risky is then to look at secondary outcomes as surrogates of the primary outcome?
It's a dangerous thing to do, because you've designed the study to answer one question, and you're basically saying, hey, it didn't answer that question very well, but it answered this one. It's the answer the question we weren't asking in the first place. And so how many secondary hypotheses are you going to come up with until your data shows something positive? There's a real sort of a fishing element to it there. And so when people, you can have stated secondary outcomes in the protocol of a study and say, we're going to look at this, we're going to look at this. This is the primary outcome, but we're also interested in these other outcomes. What I think is dubious is where people, after the study has been closed, it's been unblinded, they then they know which group's which, and then they go digging in the data to try to find a positive outcome for the study. I think that doesn't necessarily look good. It's probably
a very different approach, isn't it?
It is. And when from a statistical perspective, you're much more likely to get a kind of a false positive result. If you test 10 or 15 different hypotheses against your data, then the chances of you getting what's effectively a false positive, but being the thing that you choose to report because the p-value is less than 0.05. So I think you have to be a little bit careful. I mean, if the authors are really honest about it and say, this was the primary outcome, we didn't find anything with respect to the primary outcome, here were some secondary analyses that we did, and this is interesting, that could almost be regarded as what you might call a hypothesis generating study.
And it leads into some funding for the next research project or, whatever.
Exactly.
Also, the danger to me, I think, is when you use surrogates of a certain outcome, an echocardiographic variable or a very high biomarker and so on as a surrogate of outcome versus death.
Indeed. I mean, not wishing to get into any particular specifics, but if it didn't work with respect to the primary outcome, and you're somehow hinting that your surrogates might tell you something about the primary outcome, it's like you already know what the primary outcome was, and it didn't have an effect. And so your surrogate markers would have to be a surrogate marker of something else, not of the primary outcome, because you already know it didn't work with respect to the primary outcome. If you look at things like Kaplan-Meier curves, and if they perfectly parallel each other or cross each other several times or those sorts of things, you could do a bigger study and a bigger study and a bigger study. They still won't diverge. And also you have to say, if you had to do a study that where you needed 1,000 animals to demonstrate a benefit, or 10,000 animals, and your effect size is so small that your hazard ratio reduction is really quite small, you're going to have a hard time convincing owners that it's worth giving a drug to let's say, to prolong a dog's life by a week. It's like, I want you to give this drug that's going to cost £1,000 over the dog's lifetime, and the great news is your dog will live a week longer. So,
it's the cost benefit. Some people would pay, and on right on cue, my dog has arrived to to remind me that I should pay £1,000 a week for an extra week of her life.
I've got some bad news for my dog. That's
Listen, mine, the rehoming fee was enough. Adrian, it's been an absolute pleasure having you join us on The Animal Heartbeat. Thank you so much. What a safari through a variety of different research topics.
You might want to edit this bit out. There was a colleague that I worked with many years ago, Malcolm Cobb, and we came up with the expression that chatting with me was bollocks with Boswood. So you just had an hour or so of bollocks with Boswood, but there you go.
There's a future in podcasting right there, I think. So if you're interested and you need a producer, just look us up.
Adrian, we just have a tradition, to where we finalize our episodes and we ask our guests to pick 3 take-home messages.
One of the tips that I try to offer to people is, when it comes to statistics, don't worry about the maths, worry about the question that's being asked. Because basically statistical tests are there to answer a question that relies on data to answer it. And you don't have to worry on the assumption, not always right, that the authors will have done the right statistical test. Your job is to work out what the question was that they were asking. And once you've figured that out, then life should be easier. Maybe a second tip for a paper, if it's a good paper, try to work out what the primary hypothesis was that the authors were evaluating, and try to therefore work out what the primary endpoint or the most important result in the study was. There's a tendency in studies for there to be loads and loads of tables and loads of p-values, and you get lost in the results, and you've got to step back from it and say, wait a minute, what was the main reason they did this study? Because there's probably one p-value or one analysis in that paper that is far more important than all of the others. And that's the one with respect to the primary outcome measure. Was it significant or wasn't it? All of the other stuff is often just in there as being explanatory. The other thing and maybe there's I have to be careful that this doesn't sound arrogant, and maybe it just sounds old. But earlier in my career, when I used to read a paper and it was really, really confusing, I used to think to myself, God, this must be like a really, really detailed, complicated paper because it's really confusing to read. Now, if I read a paper that's really, really confusing, I think, God, this is a rubbish paper. It's like a good paper should be clear. It's all about clarity and getting the message through. And if you're reading a paper and having a really hard time understanding what on earth the authors are on about, it may be their problem and not yours.
I'm going to share an anecdote now. And I don't know if you remember this. You probably don't. But you were supervising me when I was a resident, and I'd written a letter. Week 1 of the residency, I said something like, the etiopathogenesis of HCM is unknown. And you said, what's the difference between the word etiopathogenesis and the word cause? And I thought for a moment and went, nothing. And you went,
yeah,
exactly.
And the difference between etiopathogenesis and cause is that about 10% or less of the population will understand what etiopathogenesis means, and about 95% of the population will understand cause. And if the purpose of communication is so that the other person understands you, keep it simple.
Absolutely. And that, for me, changed how I work. And these little moments are important. And I honestly think Words are about communication, not confusion, and I always think of you. And I think it's a good message to leave people with, maybe.
Thank you. Thanks for having me on, guys.
I know.
It's been an honor. Thank you so much.
That's great.
All right.
Bye-bye, Adrian.